Going to get started on time. We have well over 100 participants that have signed up for this webinar. It is, I believe, one of the best ones we've done or we put together with what I consider is probably one of the best panels in the world when it comes to gastric cancer. Today, tackling specifically the use of fluorescent image-guided surgery in managing gastric cancer. So we have Dr. Vivian Strong. For those who don't know Vivian, she's a professor of surgery. She's an attending surgeon at Memorial Sloan Kettering, and she's a gastric cancer guru at Memorial, probably one of the top, if not the top thought leader in gastric cancer in the United States of America. We have Professor Hwang Yang from Seoul, Korea, from the Cancer Center in Seoul. Certainly probably the world leader or one of the top world leaders in gastric cancer in the world. Masashi Yoshida from Japan. Masashi is also a pioneer, an entrepreneur, professor of surgery, and a cancer surgeon in Japan. And last but not least, we have Dr. Enrique Lanzarini from Chile, from Santiago, who is going to share with us also his thoughts. So without any further delay, I'm going to ask Dr. Vivian Strong to get this session started. For those who are attending, the attendees, please ask questions. I'm going to check your questions in the chat or in the Q&A. And when you ask a question, tell me, where are you asking this question from? Where are you from? Germany, America, Japan? This webinar is being recorded, and we would like really to know where are you calling from. So, Dr. Strong, the floor is yours.
Thank you so much, Earl. And it's such a pleasure to be here this evening. I will start by pulling up my slides. And here we go. Let me know that you can see these. Yes?
Perfect.
Excellent. So it's really a pleasure to be here and to be able to talk about ICG for gastric cancer. And I was asked to limit my slides to just 3 or 4 slides. I couldn't quite do it in 3 or 4 slides, but more like 6. And I think Dr. Rosenthal's goal here is for us to very briefly discuss our use of ICG and our thoughts, but then really save plenty of time for discussion. So I'm going to be presenting just a very brief overview. I've been at Memorial Sloan Kettering for just about 17 years now. And I would say I started using ICG for gastric cancer operations, I would say about 8 to 10 years ago, really fueled by the interest in seeing how this technology could be used to improve visualization of lymph nodes, both for the purposes of better staging, but also for teaching purposes. So I'm just going to show you an example. There are different ways that we can inject ICG, different ways to use it, both intravenously or submucosally. And I'm sure that will be subject for much discussion from the great panelists we have on the call tonight. But what I typically will do is I'll use ICG that's injected with a needle, as you can see here, into the peritumoral area from the serosal side. We have done a few cases from the mucosal side as well with our endoscopists, but typically I find this to be the most efficient way in the United States for us to utilize ICG fluorescence imaging. I use this in my robotic cases primarily. I inject about 2 cc's, anywhere from 1 to 2 cc's of ICG into the peritumoral area, making sure to get in the serosal area, but not transgastric. You also don't want to spill any of the ICG. And after about 20 minutes, we're able to see beautiful, beautiful images in many cases. This is one example where you can see the tumor that has been injected with ICG. 20 minutes later, you see tracking of the lymphatics leading directly to this sentinel lymph node. And it's not just this node, but during the course of an operation, you'll see many other nodes as well. This is a video, I think it's one of the best videos. It was actually from one of our colleagues from Italy, Dr. Spinolio, but it really demonstrates the utility of ICG. This is the gastrohepatic, right gastroepiploic lymph nodes. You can see the bottom of the stomach, and you can see in our Western patients where fatty tissue is in the way. This
We cannot see, Vivian. It's black for some reason. I don't know.
Really? Oh,
Yeah.
that's a shame.
We cannot see.
You don't see the video.
If you click on that hand, when the hand appears, see if it. Now click there. Let's see if it shows up.
Let's try this one more time. I see the video here.
Okay. Can you see it, Han? Can you guys see the video? No, it's still on black.
We cannot see it.
Oh, that is a shame.
Okay, don't worry.
Let me see if I have one other way that I could do this, because it's a nice video. Let me just share.
While Vivian is trying to share, so Enrique, where do you inject your ICG? Peritumoral, or you rather go somewhere else?
Raul, can you see it now? I have it up and running.
I see your desktop.
But you do not see the images.
No.
Okay, sorry.
I see your desktop.
I will give one more try here and see.
Yeah, don't worry.
Otherwise, I'll go on. Let me see. Share screen.
Yeah, we don't inject peritumoral. I will show you our protocol.
Okay.
Do you see something now?
Yes, now I see at least something is moving.
Okay, tell me if you see the ICG, you'll
No.
see.
No, only black screen.
Yeah, the black.
It's playing, but not visible here.
Yeah.
All right.
Sorry.
Well, it's unfortunate. It's a very nice video, but this is why I generally try not to use video technology in these kind of meetings, because there are always technical issues.
We have plenty of videos, so keep going. Don't worry.
Yes,
don't worry.
I'm sure. So what I thought would be nice to talk about is an overview of the use of ICG with fluorescence imaging specifically for gastric cancer. So I recently presented part of this at the ICG meeting in Houston, Texas, in the International Gastric Cancer meeting. And actually the first use of ICG for gastric cancer was from Japan, from Professor Hiratsuka in 2001. It was the first time that ICG, as far as my research shows, was used in gastric cancer operations. Following that, many groups, including from South Korea, particularly Dr. Woo-Jin Young, Dr. Han Kwang-young, who's on the call, will on the meeting as well, will talk about his research, have really looked at preoperative imaging of sentinel nodes in gastric cancer and the utility of how this technology can be used. In the Western part of the world, we have groups from the Netherlands, also our group, will show this data from my center, roughly 2013 to 16, looking at how ICG can be used to both identify nodes, improve lymph node yield, and also be used for teaching purposes. Here, one of Dr. Young's papers, I hope this is not one of the ones you'll be presenting. He has so many of them to enlighten us with. Looked at the assessment of lymph node dissection using ICG for gastrectomy and gastric cancer. And I'll leave the details of that discussion to him. Interestingly, in the more recent era, in 2020, 2021, there have now been randomized controlled trials looking at the utility of ICG for gastric cancer. One of them is a nice study from China looking at safety and efficacy of using ICG. They found in a randomized controlled trial that this is a safe approach, and it does identify lymph nodes. Then the Senorita randomized controlled trial in Korea, Dr. Young perhaps may be speaking about this as well, is an ongoing randomized controlled trial looking at the utility of using ICG to limit resections for gastric cancer. And it's specifically for early gastric cancer. But as gastric surgeons, we're often faced with the problem of having early gastric cancers that may be, let's say, in the proximal part of the stomach or in the fundus. And we really find it difficult to tell these patients that they need a total gastrectomy. So trials like the Señorita trial will help us to define if we can do a sampling, a selective sampling of sentinel nodes, and if that can allow us to limit the amount of stomach that we need to remove in order to adequately do a cancer operation for our patients. In Japan, there's a randomized controlled trial also, the 𝐥𝐢𝐯𝐢, also a similar kind of concept looking at the utility of ICG for early gastric cancer. And then another study, the FUJIS-019 trial, this is from China as well, that looked at the comparison of submucosal and subserosal approaches for optimizing ICG used for laparoscopic lymphadenectomy for patients with gastric cancer. And really what this study showed was that there was no difference in terms of the ability of using this procedure, whether it's being used submucosally or subserosally. So that was, I think, a very useful kind of information, but I'm sure there will be many strong opinions here of using the technology one way or the other. Let's go to our next slide. So here are a few more intraoperative photos. These are from cases of mine, both injecting the tumor, you can injecting the area around the tumor, and you can see here one lymph node bundle and how this is just lighting up beautifully, really guiding us, especially when we're doing robotic gastrectomy, where the technology can seamlessly integrate into the resections that we do. And here you see the left gastric bundle here. You do see enlarged lymph nodes, but with the ICG, you can see how easily we can actually identify these, assuring that we remove all of the lymph nodes that at least have drainage from the ICG. We published our experience, our early experience in 2016 using ICG for lymph node harvesting during robotic assisted gastrectomy, and this is the paper if you're interested. We're also doing ongoing assessment of sentinel lymph nodes. These are two of our surgical oncology fellows who initiated this prospective collection of data. You can see here another example of a tumor that we injected, the tracking lymphatics that are lighting up the individual lymph nodes in this lymphatic channel. Again, this picture that we looked at before. And really what we're looking at, what the utility is, and positive correlation and negative correlation of using ICG for our gastric cancer cases. This is not published yet. This is still work in progress, but we are trying to assess how often we can identify the sentinel lymph node, which appears to be at least 95% of the time. And then of the sentinel nodes that are identified, how often are those nodes positive or negative, and what is the correlation rate? So we're hoping to have that publication within the next few months. We also do have an ongoing trial. This is sentinel lymph node for esophageal cancer, and we're going to be doing this for GE junction cancers as well. And we are assessing patterns of lymphatic drainage and how sentinel lymph node applies to esophageal and GE junction cancers, specifically to assess the false negative rate of sentinel lymph node biopsy. So far, 35 patients enrolled through 21. We have now an additional 25 patients that have been enrolled, and we continue to move ahead with this study. So how has ICG helped our patients, at least at our center and in the West? Really, the improvement in lymphadenectomy, I think, is one of the benefits. We can definitely retrieve more lymph nodes. Our early study from 2016 showed on average about 6 additional or more lymph nodes are identified when we use this technology. Either we're resecting more or perhaps we're identifying more in pathology. But nevertheless, this does lead to better staging for our patients. The more nodes we can remove, the better we can stage them and guide post-operative treatment for chemo or observation. And I also really think that this technology aids in teaching complete lymphadenectomy. Many of our surgical trainees, they do know how to do a gastrectomy, but what they really spend time learning and need to see and have a lot of experience with is how to do a complete and good D2 lymphadenectomy. And so I think that this fluorescence technology aids in teaching, and that's a valuable thing for our patients and for our future surgeons. It may also be utilized to allow us less extensive resections for patients, but the large randomized trials, the one from Korea and the one from Japan, should help to clarify this question. So that's all I have. I just want to thank everyone. I have pictures here from the International Gastric Cancer Conference, some of our group. This is an early picture that Dr. Young will recognize when I was many years ago. I won't say how many, when I was first invited to Korea. Anyway, I thank all of you for your attention and look forward to hearing the rest of the presentations.
Thank you, Vivian. Excellent kickoff. I'm going to ask those attendees. I'm already getting hello from Bangladesh and Peru and Guatemala, the United States. Those who are attending the meeting, please ask questions. Go to the chat. Tell me who you are, where you're asking from, and we'll be more than happy to entertain your question. Vivian, before we move to Han, to his presentation, I hear a lot of gastric cancer, ICG, lymphadenectomy. How about perfusion? Have you ever used it to see if your anastomosis is when you do your 𝐈𝐒𝐴𝐺 or your 𝐥𝐢𝐯𝐞, if that is something that has good blood flow?
Yeah, so I do know that many people at my center, at our cancer center, are using ICG intravenously in order to assess perfusion. It's being used by our hepatobiliary groups. It's being used by our thoracic surgeons, including the study that I showed where the PI was our thoracic surgeon, Dr. Molina. So it has been used. I haven't been using it so far. I'm certainly not opposed to using it, but I usually am not too concerned about the vascular, you know, the blood flow in the anastomosis. I think in thoracic surgery, that is a very common concern that they have, and they find ICG extremely helpful for that.
Yeah, for esophagectomies, our leakage rate on a good day is 15%.
Yeah.
So it's a problem.
Yeah.
The 𝐈𝐴𝐺, for some reason, is not the same thing when you do the gastric tube and you do the,
Exactly.
you know, the 𝐈𝐴𝐺.
Exactly. Yes.
One last question before we move to Han. You said you inject about 2 cc serosal, or two questions, very briefly. Endoscopic or subserosal, which you prefer? And number two, what's the concentration of ICG that you use for that purpose?
Yeah. So in terms of so we've been experimenting with different amounts of ICG, and I do like subserosal, not submucosal. The subserosal, I initially started by injecting 1 cc in 4 quadrants around the tumor, and that turned out to be just too much ICG. Everything was green, and so it wasn't very helpful. So then we went to 1 cc, then sometimes we didn't have. So really, we found 2 cc's right now appears to be, you know, the sweet spot for subserosal injection. The reason we do subserosal and not submucosal is largely because I know in Korea, I've talked to some of my friends and colleagues there, where the submucosal is done a day before surgery, but in the United States, we don't have the infrastructure to have patients come in for a procedure the day before a surgery to have the mucosal injection done. And I do think that you know, that's a limiting factor. So that's why I was very happy to see the randomized trial from China, which suggested that both approaches are equally efficacious and useful. It helped me to feel more confident in the approach that I'm using.
Thank you. That question came from Professor Shaikh Aziz from Bangladesh. So thank you so much, Vivian. And I'm sure we're going to learn more about that. And it is my privilege, my honor to introduce now a dear friend, a world leader, if not the leader in gastric cancer, who taught everyone how to deal with this disease, Professor Han Kwang-yang. He's at Seoul University National Hospital. Han.
Thank you. Thank you. Thank you very much for your kind invitation to this wonderful webinar with the leaders in gastric cancer from different countries. So this is my conflict of interest. At the Seoul National, we have a faculty dedicated only for gastric surgery. You are already familiar with this node dissection is important for gastric cancer surgery. And this is the typical specimen. And very important, whether you are using ICG or not, it is important, consistent handling of a specimen, So we have a dedicated box to separate lymph node stations. So for the last 20 almost years, so we noticed here increasing proportion of laparoscope, not by familiarity of the procedure, but with our clinical study based on randomized trial. You see the class 1 for early stage, class 2 is advanced stage. And with this evidence, we apply laparoscopic surgery. And then what would be the next? This just, it's an old video, but here endoscopy injection of ICG. And then we were very happy to see that invisible lymphatics became visible. This is a suprapancreatic. You notice the number 8 as nicely demonstrated by Dr. Vivian Strong. Here's right gastric. And then you see the number 8. And here's along the splenic artery. This is area of sometimes cause complication, but with visualization, you have more confidence in the removing node. And this is along the left gastric artery. So when we look at the stomach, this is a light source on by endoscope, but your laparoscope light source is off. So it is a quite complicated network. And as Vivian, Dr. Strong showed, in 2006, it was a subserosal injection, and that was without any near-infrared camera. And now with the ICG near-infrared camera, I want to respond to Dr. Rosenthal's question about concentration. This is our preclinical study to find out optimal concentration. This is a pig small bowel. You see the higher concentration does not mean a stronger signal because of a quenching effect. So this is the proper concentration you want to use in your study. So this is first our image of using ICG camera here, near infrared camera here. Nice view of lymphatic and lymph node. It was a great, and as now a more higher resolution. Here's around the perigastric. We can see nice not only the lymph nodes but also the lymphatic channel. So our injection ICG is an intraoperative gastroscope with a submucosal injection that very nicely demonstrate lymphatics, not only the lymph nodes. Here's the gastroduodenal artery, lymph node 8, and you see the lymphatic to number 5 to right gastric. This is number 7 around the left gastric. I actually thought lymphatics from stomach comes through here left gastric, and it goes to 11P, proximal part of splenic artery. But actually, when we look at them, not only coming here, but also directly behind left gastric. So with this intraoperative ICG injection, that really helped for us to learn about lymphatic root networks. This is a number 1, number 3. That's lesser curvature part of upper stomach. With the ICG on, you see the lymphatics and the lymph node, and by overlay mode, you can see nicely. So that Dr. Strong raised the question about when to inject. Yes, many researchers inject one day before. Probably they do not have resources to do intraoperatively. We have our surgeon, my fellows, we can do this. So intraoperative endoscopic injection provides far better lymphatic visualization. And also you are guided by laparoscope view. So sometimes if some mucosal injection put needle farther, it can go into peritoneal spirit. That's a disaster. So this is one advantage. And also, you know, anaphylactic shock is rare, but it is there. So in this intraoperative setting, already patient is intubated, he can be handled. So be safe even in case of rare anaphylaxis. And also good way of a surgeon be familiar with gastroscopic procedure. And regarding the where to inject, it's depending on your purpose. If you are looking for cancer metastasis sentinel, peritumoral, obviously. But if you are looking for general perigastric lymphatics, lesser curvature, greater curvature, this multiple injection. So this is for our study of perigastric lymphatic visualization. And so here's another video. And you see the injection site here, greater curvature, and nicely along the gastroepiploic arcade, and it goes farther down. And now infrapyloric area can be visualized. And also during operation, this camera is an older version. We are not using this anymore, but still it can provide us nice lymphatic channels, infrapyloric area. You see the actual from number 6 to 14V along the supramesenteric vein, you see the lymphatics. So by using this, you can, for example, this, you might consider that might be lymph node, but actually pancreas. So the benefit of using ICG visualization can differentiate patient side versus the lymphatic you want to remove. Here's again, if I do not have that visualization, maybe I can, I did over dissection around that area that may ended up some splenic aneurysm later on. So there are some potential benefit. As Dr. Strong mentioned, we had done a few studies, bioperfusion. Even we can apply this technology for the viability of omental flap in breast reconstruction. And first, oncologic application. I mean, looking for some metastatic nodes, and so our recent publication is a mapping of a perigastric lymphatic network using ICG in advanced cancer. And at this time of our study, laparoscopic surgery was not justified for advanced cancer. I mean, class 2 was not published. So we did the open surgery, serosal injection. And here's my fellow from Germany, Felix. He looked at the lymphatics and then name it every single node. So we have here 4D. We have 8. So in one station, we have a multiple nodes. How we can differentiate it? So in one block. So for the first efficiency in one block, we can put all the nodes, but separated, differentiated by the color tattooing here, red or blue. so pathologists can differentiate. And here's some representing result: primary tumor in the antrum, and you see the lymphatic, and we now nodes 2 nodes are here, and multiple nodes in station 8, and one of number 3, one of number 8 station was positive. This is quite understandable because step by step. And one representing case here. So green means visualized by ICG, and these are visualized by ICG positive nodes, but here 2 were not visualized, and 1 was positive. So for this kind of study, pathologist is important to help. And so our conclusion from this study in advanced cancer is it is a nice tool, but it's not recommended as for the selective node dissection. And then how about facilitating surgical dissection? And so here's another view. This is probably most advanced model, and now not only a near infrared view, but also overlay. And here's again infrapyloric area and right gastric epiploic. And again, the near pancreas, you can see we can carefully, selectively remove lymphatics around that area. So question is, fluorescence-guided surgery is better than conventional for surgical dissection. And so again, my fellows, tested, this is intraoperative ICG, so mucosal injection along lesser curvature, greater curvature, and then operation time for omentectomy really near right gastric epiploic was shorter, and bleeding event was less than our propensity score matched non-ICG group. And so I usually compare with our car. There's a monitor when you are parking, moving backward. Even without this guideline, you will park well. But if there's some guideline, you have a more comfort, confidence. And we just talk about the vascular perfusion. Here's a patient who received the distal pancreatectomy, and the patient lesion is lower, so we plan to do a distal gastrectomy. But how about remnant stomach perfusion? So you see the IV infusion can staining, and this is a second to confirm. So already liver is shining there. So this remnant stomach and the jejunum is well perfused. And how about the future? And in my laboratory, our PhD students, and we are working on cancer-specific imaging. And we have developed about 50 patient-derived xenograft human adenocarcinoma with collaboration with the Jackson Laboratory. As you know, there can be multiple different targets, such as HER2, MET, and so on. So just let me show you briefly what we tried before: anti-c-MET tracer in c-MET positive tumor versus c-MET negative, and or anti-HER2 trastuzumab. My student, he worked with our biochemistry and get injected, and the HER2 positive tumor can be visualized. And also recently with the surgeumab France, they have already anti-CEA tracer, and using our CEA positive versus weak intravenous injection, here 48 hour, you see that CEA strong positive can be visualized by anti-CEA. And you may be familiar with, it has been already studied in colorectal. And here's a 𝐥𝐢𝐯𝐞 anti-CEA. And as you know, for the nerve, you can, there's a technology out there to visualize nerve. And when we have early cancer, we can not only see the ICG lymphatics or cancer-specific antibody, and also nerve to preserve in the future. So multiplex, different spectrum camera can help surgeon. And so here's my summary. Maybe we will discuss about the benefit more lymph nodes or sentinel, but I would like to summarize it here. It is obviously a benefit because we can see lymphatic channel, and so we can concentrate on lymphatic tissue, which we want to remove. So, but on the other hand, away from patient side, such as mesocolon, pancreatic vessels, or major vessels, our collaborators, and you will be very welcome to Seoul National. Thank you very much.
Thank you, Han. A big virtual applause to you. I wish you could hear it. You know, Vivian, Dr. Strong, for those who don't know her as Vivian, asked a couple of questions. And one of those, I think you can start answering for the audience. And to the attendees, please, guys, get on the chat and ask questions. Tell me where you're asking a question from. So, Han, do you think that if you do neoadjuvant, the chances or the sensitivity, specificity of this imaging technology will change?
Oh, yes. After neoadjuvant chemotherapy, the issue is the lymph node, our lymphatics are shrunk, and it even can go become a fibrotic. So maybe a few cycles, 2 or 3 cycles may not change that much, but when we do a conversion surgery, such as patient who have who was stage 4 and 1 year, 2 year chemotherapy, you probably agree, lymph nodes are really stony hard, the fibrotic. So I don't think in that situation ICG can help, and I have no idea any ICG can help in that those patients. That's my answer.
Got it. We got a question from Dr. Hiron. For the resection of the tumor, it would be the same as for liver cancer? Where can you inject 48 hours to 1 week before, if you decide to do that? It has to be endoscopically, obviously, but where would you inject if you do it endoscopically? Near the tumor? Any experience with that?
Oh, you mean from our experience, gastric cancer tumor does not hold up ICG. So the mechanism we are using ICG in gastric is it will stay in the lymphatics. So also bind to the albumin or some macromolecules to stay in the lymph node. So our application of ICG in gastric is mainly for the lymphatic channel lymph nodes.
So let me ask Professor Yoshida, who is on the call also. I have a question regarding Professor Hiron from Guatemala is asking, Masahi, what's the concentration? They use 20 milligrams per kilogram in Guatemala. What would you use to identify that, to identify a tumor?
Thank you very much. Is it about the sentinel node?
Well, they say for tumor location. For tumor location, would it also
tumor
be?
Location.
Yeah.
For tumor location, we use the 33.3 milligram per microgram per ml, quite
Okay.
diluted one. 33.3 microgram per ml.
33.3.
Yeah.
Vivian, what's your experience? How much concentration do you use?
We do the same actually as Dr. Yoshida.
Thank you.
Because I'm afraid that this distribution of the ICG, I think it should be quite limited part. So I prefer the quite diluted concentration.
We have a question from Federico Huete from Costa Rica, a dear friend of ours, surgical oncologist. For you, Han, are you familiar with any RCT showing the oncological benefits when it comes to survival, if you would do ICG lymphadenectomy versus none?
So not yet. And Dr. Strong mentioned about some study, sentinel node navigation surgery. It is probably feasible only for, not feasible. We can consider application in all this stage, but we have to be very, very careful. I want you to be very careful to interpret the results from early stage navigation surgery, because these patients are potentially curable. So even one single patient failure cannot be acceptable. And I know a few studies about sentinel node navigation surgery had failure, patient recur, patient die. So that's why in our department, we are right now running that kind of a navigation surgery, but we mark where's the limit. But we do, after marking that limit, we do a radical surgery to make sure the metastatic nodes are only within that limit. So with those, to prove that, because you know, lymph node metastasis in early stages are very low, 10%. So to prove that, you need maybe 1,000 patients.
Got it.
For the safety. So that's my current understanding.
Understood. Well, in the interest of time, there are more questions that we're going to ask at the end. Let me move on and introduce Professor Masashi Yoshida from Japan. Masashi is a great friend of ours, and also, as I mentioned before, a pioneer. And then we're going to get to the phenomenal video of Dr. Lanzarini from Santiago. So Masashi, you want to share your screen?
Oh, can you see it?
Wonderful.
Oh, thank you very much. Thank you very much, Professor Rosenthal, for giving me this opportunity. I really enjoying this webinar. And I'd like to talk about the development and clinical introduction of near-infrared fluorescent clip in the gastric cancer surgery. We have reported about the sentinel node mapping in the early gastric cancer surgery, and also we reported about the photodynamic diagnosis using 5-aminolevulinic acid. I think we can expect a wide variety of possibility in fluorescence navigated surgery. But today I'd like to concentrate on the near infrared fluorescence clip. It was initiated by Professor Sato in Kochi University. He embedded a boron dipyromethane in polyurethane and developed a near infrared fluorescent solid material. I'm a member of this team, and I'm in charge of developing near infrared fluorescent clip. This is the prototype made in 2016. The fluorescent resin stands in between the arms of the clip. We are concerned about the gripping force and the intensity of the fluorescence. Actually, the fluorescence intensity of the fluorescence looks nice at the first time when we put this on a luminal side of the porcine large intestine. But if when we put this under the thick layer of the fatty tissue, the intensity of fluorescence is not strong we thought, and the wall of the stomach is much thicker than the intestine, and the intestine from the serosal side was weakened in this situation. So we tried and knew that if the dye embedded in a polycarbonate, the intensity of the fluorescence is much stronger than polyurethane. So we employed the polycarbonate, and the fluorescent resin was attached on the tip of the clip, and now it is commercially available from Zion Medical Tokyo, Japan. And first, we performed the case series in colorectal surgery, and fluorescent clips could be detected in 94% of tumor lesions, and no adverse effects was observed. So next, we decided to apply this to gastric cancer surgery. This patient had early gastric cancer on the posterior wall of the gastric body, and we placed fluorescent clips just proximal side of the tumor, same level on the lesser curvature, same level on the greater curvature also. This patient had the prepylorus large polyp, which was collapsed into the duodenal valve. So we thought that it may interfere the transection of the duodenum. So we decided to place the fluorescent clip on the polyp also. This is the fluorescence of the clip located just nearby the tumor. And we found one more fluorescence on the greater curvature. We realized that when we raise it and the excitation light was eradicated vertically, the fluorescence was really strong. And this is the polyp, fluorescence of the polyp in the duodenum. Then we decided to dissect the duodenum just distal side of the fluorescence, avoiding the inclusion of the polyp. And this is the clip on the greater curvature and lesser curvature and the tumor side. And we confirmed the clip on the polyp, and this was prolapsed into the duodenum. Dr. Liu is my co-worker, and he worked with us in our university hospital, but he moved to Kawaguchi City Cancer Center, and I asked him to use this clip to the gastric cancer surgery, and he made a case series study, and the fluorescent clip were visible in all of 56 patients. But we had a problem that the zero clip FS was incompatible with Firefly and Pinpoint also. So we increased the concentration of the dye, and the Da Vinci compatible clip was developed. So we put the both conventional clip and the Da Vinci compatible clip on the luminal side of the stomach, and observe it from the serosal side of the stomach using Firefly. And this is the ex vivo view of the fluorescence, and we could only see the Da Vinci compatible clip. Then we decided to use it in a clinic. And this is the wedge dissection of the stomach for a small submucosal tumor. In a white light view, we cannot see the location of the submucosal tumor, but the Firefly showed us the fluorescence located on the submucosal tumor like this. So we marked on it, and using Da Vinci system, the defect of the stomach was limited as the smallest one, and the defect of the stomach is also minimized, And after that, we could suture it, and wedge resection of the stomach could be done with a minimal deformity of the stomach. This is the last slide of me. Thank you very much for your kind attention.
Thank you so much, Masashi, for a very, very, very nice presentation. I admire always your clip. You know, in America, all it matters is how much. How much does it cost? Can we get it? What's the price?
Yes, yes, thank you very much. Recently, the value of Japanese currency going down quickly. So I think it's about $350 for 5 clips.
Okay.
350.
Can we get it on Amazon, or how do we get them?
Right now, it's available only in Japan, but if you need, I will try to get it and send it to you. Some of them.
I think for the audience and for everyone as a surgeon that has dealt with GIST tumors, when they're small, when they're multiple, when you go in laparoscopically, you start localizing them. And Sang-Soo Park in Korea, that I'm sure Han has heard about, use magnets to identify the tumor. So I think the clip is an excellent option. It's much cheaper. So you can, when you resect, also make sure that the clip is there so you know the tumor is there. Again, to the attendees, please guys ask questions. Before we go to the final presentation, Han, there is a question from Dr. Perales from Texas. And Paul is asking if you are combining any tumor markers with ICG to get a better yield on lymphadenectomy.
You mean a tumor marker target? Professor, yes.
Yeah, that question, but as I mentioned, our cancer-specific imaging tumor markers, those are still investigational. So hopefully, with that development applied in clinics, what we can expect would be selected dissection. But as you can imagine, this is a long way because we need validate sensitivity, specificity. So, but theoretically, Dr. Paul Parrell's question, combining ICG, that's lymphatics, and cancer-specific imaging, by combining it, we can improve, hopefully, the efficiency of a node dissection.
Thank you. Before we go to the last presentation, Dr. Fernando Deep, who's been the immediate past president of ISFGS, and he's now the executive director of the society, is asking, and I'm going to ask probably Vivian to answer this question, if with fluorescence we are understanding different the lymphatic anatomy compared to the previous anatomical knowledge we had. Do you see different basins? Do you see better? Do you have new information about the drainage that it's helping you as a cancer surgeon?
Yeah, so I think what's really important to consider, I mean, I think that Professor Yoshida's presentation is very impressive, but I do believe that particular tumor you were showing, the wedge resection, that must have been that was a GI stromal tumor, correct? Not an adenocarcinoma.
Yes, for
GIST, yeah.
But sometimes we can perform the wedge resection for the gastric cancer, which never be has the lymph node the metastasis.
Yes, I understand. The reason I'm mentioning that point is because I think it's important for the audience to know that, you know, although there are some incredible new technologies, you know, both the application of ICG and newer technologies like Professor Yoshida's impressive fluorescent clips, these are all experimental, and these are things that are being evaluated in terms of how we can properly utilize this for our patients. So I think right now, ICG, from my perspective, at least in the United States, is a useful tool to aid in more complete lymph node dissection. In the West compared to the East, we have heavier patients. With all the fatty tissue, it can be very difficult to identify lymph nodes and to see them. They're all embedded in the fat. ICG technology, this Firefly technology, allows us to visualize and find these nodes that otherwise we really would not see. So again, I think it's valuable to help us in doing more complete lymph node dissections. Maybe it helps us to identify lymph node basins. I don't know. I think it just helps us to identify and make sure we do a good quality cancer dissection with lymphadenectomy. And it also, in that way, helps with teaching. Helps to teach the new generation of surgeons how to do a high quality lymph node dissection. In the West, I think that's one of our big problems, is the quality of lymph node dissection in centers where people aren't doing as many as many gastrectomies. We don't have a system like in Korea or Japan with centralized centers that are doing hundreds or thousands of gastrectomies. So that is an issue that we face in the United States, at least. And so that's where this technology is useful. In terms of using this to limit resections, I think that's dangerous territory because we don't have proof yet that this can be used to do less for our patients or do less lymph node dissection. And I agree with Professor Young completely that we cannot have a failure. You can't use this technology to limit your resection or limit your lymph node dissection, at least not yet. The only way that we can do these kind of investigations is in the setting of clinical trials. So I just want to caution the audience, for that purpose. We have some things we can use this for safely, but there are other areas like limiting resection or only doing selective lymph node sampling. That is not standard of care at this point, at least nothing that I would recommend in the United States.
Thank you, Vivian. Great response. So we're going to go to the last presentation from Enrique Lanzarini in Santiago, Chile. It's a beautiful video that I had the opportunity to watch. So enjoy his technique. Enrique, we cannot hear you.
Okay.
Here we
now,
go.
Yes. Yeah,
yes,
okay.
Perfect.
Thank you so much, Dr. Rosenthal. It's a great honor for me to share an example of our experience in this incredible panel of experts in gastric cancer. The video that I will show you, it's a video of a patient with advanced gastric cancer who underwent a preoperative chemotherapy with FLOT. The location of the tumor was in the body of gastric, of stomach, and in the lesser curvature. Our ICG injection protocol consists of injecting 2.5 milligrams divided in 2 points of the anterior wall of the stomach. The first at the junction of the middle third of the stomach with the lower third, as you can see in the video, and the second point in the junction of the proximal third with the medium. We do this by endoscopy or by laparoscopy with a small needle, as you can see in the video. You need to have care that don't produce spillage of peritoneum of ICG. We can quickly see how the lymphatic vessel transport the ICG to the first lymph nodes. You can see in the video. This happened in a few minutes, 3 or 5 minutes, you can see. We can see in the video in the contrast mode, the lymphatic vessels that connect the distal lymph node of the greater curvature. Now we see the same thing, but at the level of the gastrohepatic ligament. You can see the lymphatic vessel and the first lymph node in the lesser curvature. The surgery itself begins by separating the greater omentum from the transverse colon, initially towards the spleen, identifying the left gastric blood vessels and the fluorescent lymph nodes at this level, the group 4SB. Dissection is completed at this level up to the angle of His. Then dissection continues toward the hepatic angle of the colon. And once again, we can clearly see the exact location of the distal lymph nodes of the greater curvature. And we can now see the infrapyloric lymph nodes of the group 6 fluorescent. Here. Okay, this is the contrast mode. In my opinion, this is the most difficult part of the laparoscopic surgery in gastric cancer. This is the distal lymph nodes of greater curvature. We can see the mesentery of the transverse mesocolon and the group number 6. The right gastrocolic vein and the artery are identified and divided. This is the artery. So the group 4, distal, and 6 remain in the specimen. This is the contrast mode, and this is the distal number 4. We continue the surgery on the lesser omentum. You can see the lymph nodes fluorescent at this level, and the lymphatic vessels. All soft tissue over the pylorus and over the proper hepatic artery, it's removed. And the right gastric artery is identified and sectioned at its origin. This is the right gastric artery. The groups number 5 and 12 anterior remain in the surgical piece. The duodenum is divided with a linear stapler. Again, the same vision. And the en bloc resection continues from the right to the left, removing all the soft tissue above the common hepatic artery. This is the common hepatic artery. The celiac trunk until to the right crura of the diaphragm. This is the left gastric vein. We remove the soft tissue over the proximal splenic artery. This is the left gastric artery that it's divided at its origin. And we advance over the splenic artery to the distal. You can see a small fluorescent lymph node at this level. This is in contrast mode. And we remove all soft tissue along to the splenic artery. We continue dissecting the esophagus at the level of the hiatus and section it with a linear stapler again. This is the result of the lymphadenectomy, celiac trunk, the left gastric artery, and the splenic artery. In this moment, the specimen is sent for intraoperative biopsy for analysis for the margins. So in Chile, we always perform a cholecystectomy due to high prevalence of stone in the gallbladder. The pathology report the tumor near of the proximal margin, so we decided to remove a segment of the esophagus. We had to dissect the esophagus in the mediastinum to perform the anastomosis. We tested the esophagogynostomy perfusion by injecting 2.5 milligrams of ICG intravenously. The 𝐥𝐢𝐯𝐢 is seen with good perfusion. The 𝐥𝐢𝐻 mucosa is seen well. And also the mucosa of the esophagus. The esophagogynostomy is finished. It was manual in 2 layers. We continue with the 𝐥𝐢𝐻 with a linear stapler. We again tested perfusion by injecting 2.5 milligrams of ICG by the anesthesiologist. We performed a hermeticity test of both anastomosis with methylene blue, and we cut the jejunum between both anastomosis and finished the Roux-en-Y. This is the final result. Thank you so much for your attention.
Thank you, Enrique. Another country with a high prevalence of gastric cancer, as we know, Costa Rica. We have all the colleagues on the call. We are 9 minutes beyond the 8 o'clock, but I have one question I'd like to ask all panelists before we conclude, and that is, do we think that with ICG, we can develop a technique of sentinel lymph node and prevent unnecessary extensive lymphadenectomy? And let me start with Vivian, ladies first. Vivian, what do you think? Sentinel lymph node will decrease in the future the D2 lymphadenectomy?
I wish I could see into the future and see what the results of the randomized trials are. I would like to think that it could, because as gastric surgeons, we are all committed to our patients, and we're committed to improving their quality of life and minimizing the amount of stomach we have to remove. I would say that there is a role for sentinel node. Will it be ICG? Will it be some combination of Professor Yoshida's, fluorescent clips or some conjugated kind of tumor to ICG conjugate that still has to be refined? That I can't answer. But I'm hopeful that this technology or some refined conjugate technology will get us to that point.
Thank you. Masashi, what do you think?
Yeah, and the concept of the sentinel node navigation surgery is really nice. But as Professor Yang said, that we need to introduce it very carefully, avoiding the unnecessary deaths. That's all.
Thank you. Enrique?
Yes, I'm thinking in patients with earlier incipient lesion gastric cancer who don't have indication of ESB. And maybe in this group of patients, could be an option. I don't know. The trials will say.
Thank you. And Han, let's finish with Thunder. What do you think?
Yes. For sentinel, because of early stage cancer, only 20% are positive metastasis. So we are actually doing over treatment for early stage. So that's so attractive our topic to do Sentinel. As I mentioned, our department, we are running some studies. So hopefully within 1 or 2 years, we can get back to your answer for early stage. But I want to emphasize here again, Dr. Lanzarini, he demonstrated nice video, but I want to draw your attention to the tumor site. When you inject it, it was spreading away, but you may notice there's a block. Tumor area, it's not going in. So as we talked about, after palliative chemotherapy, lymphatic structures are changed, it's not going into. So same with advanced cancer with a really large metastatic node, because it's blocked by cancer cell, ICG will not go there. So that's one thing you have to consider for like a cancer specific, Sentinel, or you want to trace cancer for advanced cancer, as I showed in my presentation. Same way, we have to be cautious. So I agree with Dr. Strong. At this moment, this is a nice technology to facilitate the surgical dissection or education.
Well, I want to thank all the panelists on behalf of Dr. Deep, who is on the call as an attendee. I don't know why. Electra McDermott, who is our managing director, myself, ISFGS, those who've never been before in one of our webinars, ISFGS.org. This is one of the very, very few things that it's very good for you, and it's for free. So join our society, participate on the webinars. We have a dosing chart online and patient guidance, patient portals, et cetera, et cetera. So thank you everyone for staying late, and have a wonderful day, wonderful evening, depending where you are. Thank you. Good night.
Good night.
Good day. Bye.